Hey guys, my name's Sam. Welcome to Prep Medic. This week's video, we are going to go through our critical care ground ambulance. So some of you guys might be watching this and slightly confused why I'm in a flight suit sitting in an ambulance. We do a 24-hour shift on the rotor and a 24-hour shift on the ground every week, and they don't feel like getting a separate uniform, so we are always in these super sweaty flight suits. Now, this ambulance is pretty unique. Like I said, we're a ground critical care truck. It is set up almost identical to our helicopter, and our mission set is very, very similar. Now, we do mainly interfacility transports when a patient has things going that are out of the scope of a standard ALS ambulance. These are things like ECMO, Impellas, balloon pumps, high-risk OB patients, patients that are intubated, patients that are on a lot of different medication infusions, including vasoactive medications, or patients that require more advanced interventions like potential for RSI en route to a separate facility. In the summertime, usually we're doing more non-emergent trips. So we're taking patients that do need higher levels of care, so we're going to tertiary facilities way out on the eastern plains back into the mountains, but conditions that are not like hyper emergent. So they're going ICU to ICU for a procedure tomorrow. They have to get there, they have advanced things going on, but it's not a super big emergency. It's just way more economical to go by a ground ambulance. In the wintertime, when our rotorcraft are down for weather more often, this truck will kind of take the place of a rotor, and we'll be doing more of the emergent transports when that helicopter can't fly, because once again, these interventions are usually out of the scope of a standard advanced life support ambulance. So the ambulance I'm sitting in right now was made by Horton Emergency Vehicles. It is a freightliner quad cab, and this thing is absolutely massive. Like I talked about before, we have a lot of really large pieces of machinery we transport in this thing. We have a larger crew complement of an EMT, a paramedic, and a nurse. So that extra space is really, really nice for us. We don't have to send somebody to the back of the ambulance on a dead leg or responding to a call. We can all be up in the cab, have conversations, keep people awake and entertained, and kind of game plan what we're going to do. Now, it is also pretty common for us to have paramedic students riding with us, and then we have MOUs with the local 18 Deltas, so our Green Beret medics will come and ride with us just to keep their skills sharp and experience kind of a different side of medicine that they're not seeing in combat zones. So it's really nice to have those 4 seats up front. This ambulance does have a full emergency lights package, but I'll be totally honest, we hardly ever use those just because we're doing a lot of interfacilities. These patients are already at hospitals. The 30 seconds, 2 minutes we're gonna save running lights and sirens just isn't worth it, especially when this thing is governed at 75 miles per hour. It just doesn't make any sense. So coming to the meat and potatoes in this ambulance, we have 3 seats in here. We've got this seat right here, which is where the patient attendant will usually sit, the person that's physically working on the patient. We've got a CPR seat here, which we don't do a whole lot of CPR in here, so generally that's going to be a student, a third rider, or a family member for transporting a pediatric patient. And then lastly, we have the captain's seat, which is where the person that is charting usually sits if there's not more intensive hands-on things to be done as we're transporting the patient. It's just a nice place to kind of sit out of view and do what you have to do to get back on the road faster after you drop the patient off. So the cot itself is a Stryker auto load. Obviously, it's really nice to have that capability. We're not lifting all of this weight into the ambulance. All the trucks in our fleet have it, including our 911 ambulances. So really grateful to have that technology. Right here, we carry most of the stuff that we're using on every single patient call. It just lives on this cot, so we don't have to stow it in a cabinet and get it out every single time. Usually we've got seat belts around it just so it's not flying everywhere. For this video, obviously I have everything unbuckled. So first and foremost, let's come to the first out bag, we call it, you know, the main bag, the red bag, whatever nomenclature different staff members use. But this is what we're taking in for every patient, and it can handle a majority of the stuff that we're dealing with. It is a stat pack, unsure of what model, but it works just fine for us. Up here, we've got all our controlled substances. So in this bag right here, we've got our ketamine, our fentanyl here, our midazolam, and then our morphine. Now, you'll notice we have a ton of these meds, and that's simply because we are responding to very, very rural areas. We are going all the way out into the eastern plains, almost to Nebraska. We are going to the Continental Divide, into the mountains, to a lot of these critical access hospitals where they have somebody that's intubated, sedated, requiring a lot of measures on the way to a hospital, and we might be on the road for several hours. In these cases, we have to be able to sedate these patients for a prolonged period of time, just so they're not feeling any pain. They're not coming off the cot, taking out whatever interventions are in, such as a tube. So it's really necessary that we have these meds. Now, for anything we don't have here, we have the ability to get it from other sending facilities. So it's pretty easy for us to just ask them, hey, can you send us with an extra bottle of propofol or things like that. Now, in here, we have our paralytics and one more induction agent. So paralytics are what we use in rapid sequence intubation just to make all the muscles relax, essentially, but they're not a sedative. So we use primarily rocuronium, and that's what we have in here. We've got rocuronium. We got rid of our succinylcholine just because we just weren't using it in our RSIs. It really doesn't have much utility for us in this environment. We also have etonimidate for a secondary induction agent, and for whatever reason, that's not a controlled tagged substance, but it is used to basically put somebody to sleep for a breathing tube to be placed. This bag also has an RSI checklist in it, and then deeper in this pocket we have a bag with a bunch of different syringes that essentially let us give the medications that we carry, as well as draw blood as needed. All right, looking at the right and left pockets here, we've got a glucometer on this side, nothing special about that to check blood sugars, and then we have an IV start kit on this side. We don't do a ton of IVs in this realm, just because we're doing a lot of interfacilities or we're tiering with other ambulances, and most of the time they have stuff ready to go. But just in case they don't, we have the ability to start an IV, or if somebody's IV goes bad en route, we can do that. Always really good to have a lot of flushes in critical care transport, because we are always giving meds, and then those meds have to be flushed in, or we have to check lines, etc. In here, we've got our Easy IO, which for those of you guys that don't know what an IO is, it's essentially an IV that goes directly into the bone, and it's inserted with what is ostensibly a Makita drill. So it looks really barbaric, but it's a very, very good procedure for patients that are in severe states of shock or in cardiac arrest, where their veins might not be standing up, might be a really hard stick, or we need to get a medication in seconds and we just don't have time to go for that IV. Just a nice tool to have over there. On the other side of this bag, this is all our blood administration equipment. So we do not carry blood on this ambulance like we do on the helicopter. On this rig, we can usually get it from sending facilities, so we weren't using that much, and we just kind of gave our stock to Rotor, but we are still giving it pretty regularly. So before I get into that, in this side, we've got our QuinFlow puck. So this is a blood warmer or fluid warmer. In this puck, there's just a coil of tubing that goes around the heating element, essentially, and this will warm the blood substantially as we give it to the patient to prevent hypothermia in our fluid administration. And then we've got gravity tubing and an extension set for this guy. This just sits next to the patient, and then there's a base station that connects into it, and I'll show you guys that when we get over to the cabinet itself. Down here, we've got a 500 bag of saline for our blood set, and then we've got a wide filtered blood set right here that we can spike if we're giving it, and we've got a pressure bag to put the blood in, or if we're doing an IO, IOs require a pressure bag to actually flow fluid efficiently through them. All right, so coming into the lid of the pack, these two cases are kind of cool. So first thing we got in here, this is like our chest pain emergent cardiac bag. So in here we've got our adenosine, which is a medication that can stop certain arrhythmias. We've got a 5 ml syringe, a blunt tip. We've got some aspirin, heparin, and then our nitro spray for, like I just said, chest pain, STEMIs, that kind of thing. And then this is our push dose pressor kit. So for those of you guys that don't know, push dose pressors are a medication that you're giving really quickly to raise somebody's blood pressure. This is done by either constricting the blood vessels or increasing the heart's contraction. So in here we have everything we need to mix push dose epi and push dose neosynephrine, which both do slightly different things. We do have to mix both these, so we got TIE fighters in here, syringes, and stuff that we can reconstitute it to the concentration that we need need, and then push it as needed. Now on this truck, we are always doing that as a bridge to more sustainable therapies. So we are always using that to either counteract post-intubation hypotension or pre-intubation hypotension, or to bridge them to a drip vasopressor of some kind. Usually we're going to be using Levafed in this realm, which we do carry, and then we also get it from facilities there as well. Coming into the main pocket of this pack, this is a stat pack, but we use a lot of third-party packs in here. I think these are by Conterra here, and they just fit our stuff a little bit better. So this right here is all our half sets and full sets for our pumps. So these are specialty tubing that fits into our Sapphire IV pumps. Now we carry 5 of these on the truck. These allow us to give very specific doses of medications, and we're not counting drips in the drip chamber, trying to make sure it's accurate. These guys right here are super, super handy. They're very small. Like I said, we carry 5. They are single channel pumps, which kind of suck. And then we'll keep like 2 on the cot because that's kind of the average we're using, although we quite often use more than that. So these are programmed with our entire blood library or drug library in them, which cuts down on the potential for mistakes. It does all the med math for you, lets you dose it really, really easily. So all those calculations you learned in paramedic school, you don't really have to use them here. But these also give us the ability to manually program things in. So if we're going to a facility that isn't owned by the service I work for, and they're using different concentrations, they're using different medications, I can just program in what is the bag it's in, what's the concentration of medication, what's the dose rate, etc. And it will do all the med math internally. I don't have to really do a whole lot of thinking. I just usually verify it on an app that I have on my phone. And then we're always doing partner checks as well. So, you know, we're always bouncing dosages back and forth between the nurse and the paramedic. So a really cool tool. I wish more 911 ambulances had them. They're super easy to use and save a ton of time. They're way less risky as well. So in here, we've got a lot of Airway stuff. That's actually what the primary purpose of this pack is. Right here, we've got a McGrath video laryngoscope. So a video laryngoscope is a device that's basically used to look down somebody's throat at their vocal cords, and then we can pass a breathing tube through those vocal cords. It secures the airway. It allows us to breathe for them much more efficiently without taking people to hold a mask seal. We can connect them to a ventilator. We can control their hemodynamics, and then it protects them from any potential aspiration pneumonia here. So you can see right here, it's a camera. It shows you everything right there. We've got blades that connect there. Now, one of the reasons I like the McGrath is because it is both a video laryngoscope as well as a direct laryngoscope. So if I gum that camera up, I can't see anything on there. I can then just go and look direct and see if I can see the vocal cords with my own 2 eyes. So it's a really cool device. Used it quite a lot and really have had 0 issues with it whatsoever. So we carry that in this case. And once again, you'll notice this isn't the official carrying case. This is something we found and made it work. So in here, we've got our eye gels. Eye gels are a backup airway. So this is our plan B if the intubation didn't go as planned, or if the patient's hemodynamics won't support a endotracheal tube or what it will take to place one. These are a simple supraglottic airway that they're dummy proof. You can shove those basically in a patient's mouth. They seal around that airway, and they allow you to give your breaths through a ventilator or BVM. These are really good for normal-sized people or normal proportioned people, but when you have somebody that has some congenital abnormalities, really, really tall, really, really short, like kind of all of those extremes, I've noticed these do have a failure rate to them. So they are dummy-proof, but that doesn't mean they're going to work 100% of the time. And like I said, these are our kind of plan Bs as it goes. And then for a plan C, that becomes a cricothyrotomy, which is what's in this bag right here. Cricothyrotomy is just cutting their neck, inserting a tube directly into there. I'm sure you've all seen, you know, The Heat with Sandra Bullock. She does it with a pen and a straw. I don't recommend that. This is the official tools for that, and that lives right in here as well. So then, of course, we need a way to bridge them over to the ventilator. We have a bag valve mask, and this also has our OPAs and MPAs, our simple airways, right in here. We carry a pediatric BVM, not an adult BVM in here, just because that tidal volume fits for most adults, and we don't have to carry such a big, bulky object. There's a lot of data out there on that, and a lot of services are switching to pediatric BVMs only. We do have adult one, but we never use it. In here is all our ACLS medications. So in here we've got our epinephrine 1 to 10,000, our atropine, lidocaine, amiodarone, 10 ml syringe, blunt tip needles, D50, and then 2 things of Narcan for a reversal agent. And then last but not least, in the main pocket of this bag, we have our Airway roll. So this Airway roll basically has our direct laryngoscopes if we're not going to use video. Video is usually our go-to, but it's technology. It can fail, so it's good to have a backup here. Same thing, except instead of having a video camera, we use this to lift the airway manually and visualize it with our own eyes. I'm sure you've seen it like Scrubs or Grey's Anatomy, you know, when an anesthesiologist comes in there, bam. Nobody's ever done that in real life because it can send this blade flying. I'm actually surprised it worked right there. But if you want to feel cool, that's one way to feel cool. So we've got both Mac and Miller blades in there, which if you don't know what that means, don't worry about it. They're just different sizes of blades. We've got a bunch of our ET tubes in here, so we have to open this no matter what. We've got tube securers, and then we've got McGill forceps for retrieval of foreign objects. If we get in there and we're choking on a hot dog, we can pull that hot dog out. And then lastly, in here we've got PPE, so goggles and masks. I'll tell you from experience, you go in, you get close to somebody's airway and you're pulling something out, it's pretty easy for a lot of vomit and other stuff to come up and splash you in the face. Unpleasant experience. So more important than gloves, in my opinion, are face shields for intubation. At the bottom of this bag, we've got a T-pad pelvic binder, and then we have bougies, which are something to assist with intubation. Now, this top pocket is our trauma bag. And I'm going to try to open this without getting this absolutely everywhere to show you some of the stuff in here. But basically in here, we've got Quick Clot to pack wounds. So we've got Quick Clot to pack wounds. We've got our Halo chest seals is what we use because it's what we can get from our supplier right here. We've got 2 cat tourniquets in here out of the wrappers, ready to go if we need them. And then we've got our ARS needles for decompressions. Kind of the one abnormal thing in here that you won't see in a lot of other ambulances, we actually have everything we need to do either chest tubes or a finger thoracostomy. Now, we're not doing chest tubes on scene calls. Those are pretty much reserved for interfacility transports. If we're out at this critical access hospital, they're not comfortable doing a chest tube, we can throw one in before we transport if the patient needs one, or we can do it en route. But on our scene calls, we have the ability to do a finger thoracostomy, which is like the first 5 steps of a chest tube minus the tube insertion. Really, all you really need for that is going to be this guy, some forceps, and your finger. And this is a scalpel. So kind of a cool capability to have if the needle decompressions aren't effective or if the patient has a bigger issue that can be taken care of with that. And then lastly, on this pocket, we've got a manual BP cuff if we need to take that. And then we've got a temp sensing probe and some wires for our invasive monitoring hookup. So if we have a patient on an A-line, a Swansgon catheter, they're got a balloon pump going, and we need to connect that invasive monitoring directly to our monitor, we can do that pretty easily. Now, if I believe we have 3 of those cables in here, and we can monitor 3 lines on here. If we have a patient that has more, like our ECMO patient, somebody like that, we usually have a perfusionist on board with additional monitoring equipment that we can plug that into and kind of decrease the load on our own stuff there. And then last but not least, we have medical restraints. So we're not really taking psych patients. It's not something where like, hey, they're intentionally trying to hurt themselves. This is the patient that, sedation might be wearing off a little bit and they're reaching for their ET tube. We just want to keep them safe and keep that airway in place as long as it needs to be there. All right, lastly on this cot, we've got 2 kind of cool pieces of equipment. Right here we have our Zoll X-Series monitor. So the Zoll X-Series is a cardiac monitor, is the capability of doing a 4-lead EKG, a 12-lead EKG. It also has all our vital monitoring equipment on it. So it's got an automatic blood pressure cuff, pulse oximetry, like I said, that 4-lead EKG, and then we can do our invasive monitoring with it. So that's pretty cool because then we can take all of the readings it got through the entire call and we can download it directly into our chart, timestamps it perfectly, puts in all our waveforms on that monitor, and it just saves a ton of time for us. Additionally, this thing can do synchronized cardioversion, it can do pacing, as well as defibrillation. Now, we always do manual defibrillation. It does have an automated defibrillator mode, but we just don't use that a whole lot. Now, lastly, this is something that you won't see on a lot of ambulances. This is a Hamilton T1, it's a critical care ventilator, which is essentially mechanical lungs for a patient. It allows us to breathe for people that are intubated. And then it also has the ability of doing CPAP and BiPAP, which is positive pressure ventilation for a patient that is conscious. Now, this has a lot of different settings in it. It's got a lot of different ventilation modes, and it's something that really takes a long time to perfect your use of it. But this machine is also really smart. So you can put in the patient's height, and it's going to calculate its ideal body weight. And then from there, it's going to calculate their tidal volume and kind of recommended initial rate and all of that stuff. So it kind of does a lot of that work for you. You can't trust it though, and you have to do your own calculations and make sure it's within the ranges that you want it to be. So a lot of different features on this. One of the cool things, if you have a patient that's intubated, that's on a nebulizer, you can hook the neb directly into this device, and then it will actually administer that neb with its ventilations, and it doesn't waste any medications. So really, really smart device, and a lot of different features on it. We use this guy all the time. So over here, these are the cabinets that also connect to the outside. This is just a lot of our ancillary equipment. So stuff that we're not necessarily using every day. In top here, we've got our vent bag. So this just has our vent circuits in it. It also has some extra connectors. We don't always transport from our own facilities, so people have different O2 hookups. We've got wrenches in here and just things to make sure that their equipment will work with our stuff and we can facilitate the transport of that patient. In here, we've got our extra Sapphire pumps, and these are usually plugged in this cabinet, so we cycle them out from what's on the cot. And we can use all of these pumps at the same time. It's not uncommon to go on patients with 5 or more drips. Last thing on this top shelf, we have our Quinn Flow base station warmer. So this is what connects to that little puck. This is what actually supplies the power and warms the blood and fluid as we administer it to the patient. Works really well, just a little bit bulky in a lot of instances. In here we have our medication bag. So this is everything else that wasn't in that first out bag. Tons of different medications, and then we actually have protocols for even more stuff that's not in here that we'll just get from sending facilities before we transport. I'll leave a list of meds up here for you guys to look at, but there is quite a lot of stuff in that bag. Lastly, in here, we've got our, this is our Eden monitor. So this is a TOCA monitor, fetal heart rate monitor, and this allows us to just place some probes on a mom's abdomen and monitor her baby for transport. So we do our what we call high ROBs, high risk OBs. These are our preeclamptic patients, our placenta previa patients, preterm labor, PPROM, things like that, where that baby has to be monitored as well as mom has to be monitored. So that's what this guy is. It is tagged because since it's not something we use every single day, we don't want to have to check it every day. So we just make sure the tag's there, and then we know anytime this tag is reapplied, a checklist has gone through to make sure what it needs to be in here is. And then we've got a portable suction device, which is hardly ever used. Coming down to the second layer of cabinets down here, we've got kind of an ancillary bag, and this just has like a traction splint in it. It's got some extra vent circuits in it, as well as some extra monitoring cables, an extra pump, just the things that if you're going on that patient that just has that extra little bit of intensive care, it makes sure we have what we need. And then we have our pediatric bag right here, which is primarily airway adjuncts that are appropriately sized. It's got our smaller ET tubes. It's got BiPAP masks in here, smaller nasal cannulas, etc. So that kind of thing's in here, and then our monitoring cube, which has like our smaller blood pressure cuffs. Nothing super crazy. We don't really use a hand-heavy system. We have Broslow in there, and then we use different apps depending on what is going on with the patient. So on this countertop, we have an attendance light just so we can do paperwork and everything over here. We've got a control panel, which basically controls our oxygen, suction, interior lights, heating, cooling. One cool thing this ambulance has that I can't show you right now because it's off is this is privacy windows. So if you hit a button, it does something to the windows and they defog. Or if you want to preserve the patient's privacy a little bit more, you can fog them up and nobody can see in or out. So kind of a cool feature, to tell you the truth. We've got our base station suction right here. We've got some extra O2 ports on this side, and then headphones, which we really never use. We could talk to the driver up there if something's going on. back here and we can't just yell back and forth. In here, it looks like an easy IO thing. It is not. It is an iStat, which an iStat is basically a portable lab machine, for lack of a better word, that allows us to draw arterial blood gases and venous blood gases. We've got CG8s and CG4s. So they let us get, the patient's metabolic status. Are treatments working for them? How are they oxygenating? How are their organs oxygenating? It shows us all of that right here, acid-base status. So the cartridges we carry CG8s and CG4s. CG8s have a lot of our electrolytes on them, and then our CG4s will allow us to see lactate. Now we can draw ABGs and VBGs off of VAMPs or off of peripheral IVs, or we can actually do an arterial stick and draw that manually. So it kind of depends on the patient condition. Obviously, if they're intubated and sedated, they don't have an A-line, it's pretty easy to do an arterial stick and get some of that blood. It's not hurting them because they're already sedated. But if the patient's conscious, obviously we're not just going to go straight to that stick if we can help it, and we might go to draw off a pre-existing IV or do a venous stick to get those labs. All right, so as far as cabinets go, like I was saying before, we don't really store anything that we operate out of in the cabinet. So we got these guys here. This has a lot of our Airway stuff, so just extra vent circuits, O2 masks, BVMs, O2 connectors, suction stuff, ultrasound jelly, extra connectors here, extra masks, that kind of thing. And then over here on this side, we have kind of our like more normal stuff, I guess. So like masks, procedure gowns, isolation gowns, our SpO2 sensors, SAM splint, some of our extra T-pods and trauma stuff right there. And then lastly, for our cabinets, we can come down to this guy right here. And this is just kind of a tree of drawers. So down in this one here, we've got our trash. Up here, we've got everything we need for IVs and to restock for syringes and med admin. And then right here, it's just got all our extra pressure bags as well as IV sets if we're starting more drips back here, once again, want to restock our bags. You'll notice one of the cool things about this ambulance is that we've got O2 connectors everywhere. So this is one of our fast connectors. We've got them, on the ceiling right here. And then we've got a couple on this side as well. Now, I've never used this feature on the captain's seat, but here we can pull this down, and that is a car seat if we have an extra pediatric patient that needs to go with us for whatever reason. And you'll notice that these seats all have airbags right here, so things to protect us. It's a relatively safe ambulance, which luckily we haven't had to demonstrate yet. I hope this video is helpful. If you guys have any questions on what this ambulance does, what we carry, please leave them in the comments down below, and I will see you next week.